Welcome to Conversations About Construction. I'm Dave Trafford. This podcast is produced and presented by the Residential and Civil Construction Alliance of Ontario. Members of the Alliance build your homes. They build your transportation networks and the systems that deliver safe, clean drinking water to your kitchen sink. This series will focus on industry innovations and solutions that support sustainable economic development and Ontario's world-class standard of living. In this episode, we'll tackle hallway healthcare. Our guests are Michael Fenn. He's the author of the report, Prescription to Cure Hallway Medicine. Michael is a senior advisor at StrategyCorp and the founding CEO of the Mississauga Halton Local Health Integration Network. We're also joined by Phil Rubinoff. He's a builder and developer and the chairman of the RCCAO Board of Directors. It has become an issue and a topic of not only national interest but national attention, but national concern, to the extent where Canada's public health officer has called this a national tragedy. And that is about talking in terms of what has happened in long-term care facilities in this country through the COVID-19 pandemic. And it sounds like a long, big issue that we're going to have to tackle in the short term, because we can't let this happen again. Part of the solution will be housing. Housing in terms of managing the flow of patients from hospitals to long-term care facilities and somewhere in between. And oftentimes the conversation has come up lately that the best place for people to be treated, whether it's COVID-19 or not, is in their own home. So the folks at the RCCAO, they were rather prescient in all of this, managed to publish a report about a week and a half before the pandemic was declared, it seemed, here in Canada. And it talks about that very thing. Michael Fenn penned the report. He joins us. And Phil Rubinoff is the chair of the RCCAO, both joining us now. Thanks for being here.
My pleasure, Dave.
Our pleasure.
So let me start with you, Phil, because I know this is one of those things that sort of was a burning interest for you, and certainly it sounds like when you initiate this idea around hallway health medicine, that's where the conversation started, that it is a bit out of your lane as an infrastructure organization. How did you guys pull the thread through initially to say that this was a solution to hallway health care, and that housing was one of the major issues that you were going to tackle?
Well, one of the issues that came up, actually, and it started back in 2015, was a discussion with Michael Fenn, who wrote a long document about government spending money smartly in a changing environment. The changing environment, part of it was hospitals were probably going to change over the years as people were not staying in hospitals for long terms after operations. It was in and out type of surgery, same day, etc. And what happened after that was that discussions with various people over the years were indicating that seniors were using up a lot of hospital rooms in existing hospitals because sometimes they were living alone, they had no other place to go, they had trouble finding residents that would look after them from the hospital. And the discussion started with Michael about doing a new paper on that situation. So Michael said, yes, sounds like a good idea, and he took over.
Yeah, and Michael, when we look at that, this has been a long-term problem, and we talk about long-term care, but this problem has been around for a long time because, every 5 or 6 years we'll hear reports coming out assessing the quality of care in long-term care facilities and the nature of the care that our seniors are getting. So all of this, the confluence of all of these issues really come home when we look at the pandemic that we're in the middle of. we could have prevented what we're in the middle of.
Well, I think one of the insights that Phil had originally, which I think is the root of some of this, is that we have a gray tsunami of baby boomers heading towards the healthcare system. None of us are getting any younger, and eventually all of us are going to need support in our housing and medical care in a variety of forms as we age. And so it's a straight numbers game. But I think Phil's insight was that the problems in hospitals maybe go beyond the hospital door, that in fact it might have something to do with the accommodation that we provide when people want to leave hospital, and how we look after our really frail elderly, and then at the other end, how we keep people from needing acute care, because the hospital system is really set up for acute care, not chronic care, and how we can keep people in their homes and in the community and get them the kind of accommodation that reflects the changing lifestyle that they represent, as well as the different kinds of housing that people need over time. So I think the insight was really that we have this big wave of demand heading towards the healthcare system, and we need to have ways in which we can reduce its impact both on the front end and on the back end in terms of the impact on the hospital system. And as you say, Dave, when it comes to long-term care, I guess our conclusion is you just can't build enough beds, and the challenge that we're having with long-term care is the one that sort of manifests itself as a result of the COVID-19 experience, which is you can only make so much use of those facilities before you get overcrowding there too.
Well, and I guess the other side of it is how we integrate that as well into community, because that is the biggest issue we've seen in terms of the long-term care facilities during the pandemic has really been amplified and highlighted, is this even further level of isolation. So the degree to which some of those patients or some of those residents could be incorporated more into what is considered community as opposed to the facility itself is an important part of the conversation, right?
Yeah, part of it was in our original discussions with Michael was step-down facilities that were part of almost like a campus-type arrangements where people that, especially we're going back and talking about seniors, had a place to go that was close by to the hospital where they could have a much lesser type, like not hospital type, but a lesser arrangement for them to be housed and looked after right beside a hospital. And there's places and land generally around hospital locations where there is excess land that could be used for these type of step-down facilities.
Yeah, I guess that's the whole issue. Again, we come back to planning and preparedness, right, Michael? And in as much as that it will require us to break some institutional molding to allow that to happen, whether it's because it's a municipality that owns it or a school board that might own some property that would be useful. Now we're talking about provincial government because it's the healthcare system and long-term care.
Well, I think that's true. Certainly it's going to take what they often call a whole of government approach. The gap that Phil and I identified really was in a hospital setting when somebody's ready to be released. Often the choices are the stark choices between either going home, which isn't a viable proposition for many people, particularly in the near term after a hospital discharge, or going to long-term care, where there's quite a queue, and the level of acuity that's required there is a barrier for people getting into those facilities just because there's not enough room. And so I think what Phil mentions is there's a whole opportunity to lessen the burden on the system by the infrastructure you would put in place to allow people to move out of hospital, get restored to some level of health and independence before they go home or before they go into a community setting, and that would take pressure off the hospital because you don't have bed blockers, as they call them, and you don't have overcrowding in the long-term care setting because people, a number of those people would not go to long-term care. They'd get stabilized to the point where with support they can go home or go into a community setting.
Did your study, and when you started to look into this, did it show where the blockages were in the system vis-a-vis planning? I mean, I would think that I wouldn't think, for example, that anybody in their right mind would disagree that we want to make sure that this is efficient and we spend our money as well as we possibly can, make the best use of our resources. Where's the obstacle here?
Well, I guess Phil may want to comment, but I think to some extent it's that we haven't been thinking about seniors specifically and their different kinds of housing needs. We tend to look at things like generating more density, and we assume and more individual units, and that empty nesters could move into condos, and therefore they're looked after in the same way as young families starting out would be. And I guess our conclusion was, no, you need to target seniors as a class of accommodation quite specifically, and recognize their needs aren't uniform even within that group. You have a lot of quite agile and quite able and independent seniors for whom a bungalow, single level accommodation without a whole lot of obligations to maintain the property might be quite satisfactory for active seniors. As they get a little older, you might want additional supports. As they're into situations where they're depending on medical care, then you get into the kind of thing that Phil was talking about. So when we're doing zoning, when we're doing planning studies, when we're doing housing studies, we need to recognize that you do need to discriminate among the different groups of people in order to get the right kind of housing. And I think, frankly, Phil's had a lot more experience in this than I do, but I think if you went to municipal councils and say, we want special arrangements that are going to be targeted at accommodating seniors, the general community is not going to oppose that in the way that you might run into problems with other types of targeted use.
Phil, you got a thought on that?
Yeah, no, seniors have a special place insofar as rezoning, and it could be done and will be done. But the problem is there is a lack of government funding, I guess, for building these kind of things, because the affordability issue becomes a big issue as well. And as we've seen with COVID, that there's certain types of accommodation for seniors that are not suitable. They have to more or less have individual rooms rather than multiple beds in a room. It's a situation that will be changing on an ongoing basis because of what we've just gone through with COVID.
Yeah, I guess the whole idea then when we start to talk about planning and construction and design, it's not very often, I guess, Phil, that infection control becomes part of the conversation in an infrastructure discussion, but really that's what you're talking about.
Yeah, it has to. It has to become part of looking forward where and how not only hospitals are built, but how seniors' residences of various sorts, because as Michael has just said, a senior can go in at a certain level of, require a certain level of care, and as they move through the system and get older, they need different levels of care. So I know that there are there's situations out west, that one place where my daughter worked at, where there was 3-4 different buildings where different levels were required, and people were on their own at the first stage and full care at the last stage of their lives. So that's very important.
Phil, is there a capacity, though, within the industry to deal with what sounds like will be a fairly significant need in units and housing? Do you guys have the capacity within the infrastructure sector to make sure that we can take care of this on top of everything else we need?
The capacity of the industry is great and growing. I mean, the number of units of high-rise that are being developed right now, built on an annual basis, is about 18,000 to 20,000 housing units a year in condos alone, without low-rise. So that there is capacity, and some of these buildings will become these kind of residences for seniors.
Dave, coming out of the COVID experience, there's a couple of things that are going to be sort of facts of life. One is that while people may want the government, for example, you hear calls for the government to take over the long-term care system and run it all itself, and other suggestions for greater government intervention into this issue at various stages. I think we're going to find that our fiscal position is pretty heavily committed, and so we're going to need to find ways in which we can use the tax system and the pension funds and other sources to make this a worthwhile proposition both for government and the private sector to produce the kind of accommodation and the kind of healthcare supports that we're going to need. It's certainly going to involve government, but it also needs to involve the private sector. It can't rely on one or the other, and we need to put in place the kind of economics that would and fiscal arrangements that will make that possible, in particular for the seniors themselves. And maybe the wealthiest generation of seniors in history, but there's a limit to what they're going to be able to afford, particularly in their declining years. So we need to find ways in which we can do this economically and provide an economic model for people to invest in it.
Yeah, I know you in your report you touch on a couple of sort of innovative ideas, I thought, and that was also the notion of using the equity in the homes that they have been in for the last 30, 40 years to be able to somehow make that transition and support them in their housing needs as they get older. Explain that a little bit more for us.
Well, I guess you see some of that on television all the time about reverse mortgages and things of that kind. But what I'm really suggesting is that a model that says we owe it to our seniors to pay for them right through their whole aging process, it may be worthwhile from a philosophical point of view, but whether given the size of the baby boom cohort and the Gen Xers and others who are going to have to pay for all that, we need to find some smart ways to do this. And I think in the report we said something along the lines of the right treatment at the right time in the right location by the right provider at the least cost to the taxpayer. And that last one can't be ignored. If we're going to be successful with this, we need to make sure every dollar that we invest in the long-term care and the hospital and healthcare system and in the accommodation of seniors is well invested and sustains us over time.
Yeah, it's interesting that you should say that as we kind of move this forward. I was talking to Dr. Danielle Martin recently, and she is a VP at Women's College Hospital. And it is her view that there is enough money in the system already. To your point, Michael, we just are not smart enough about how we allocate them to make sure they're used effectively. And whether that's technology or in terms of where we put our hospitals or our clinics, locations, how we interact with patients, all of these things are going to have to be part of that conversation. And this housing issue becomes central to it in many ways.
There's another aspect to this, of course, is that most seniors want to stay in their own homes for as long as possible. Now, the definition of home does not have to be, a big house or a big apartment. It could be a smaller place for them to be maintained on their own and look after themselves, which is their desire. To go into these large institution type of buildings is later in life. Earlier in life, if they had more home care, they would be very happy to be in their own place, so to speak.
Yeah, again, we bring up the whole notion, given our experience recently, though, around infection control. So people coming in and going out of your house, that's going to have to be reviewed. Given that experience, and Michael, the work that you've done so far on this report, what's the logical next step we need to take, and what do you think the realistic expectation should be?
Well, I think some of it goes back to the point you made a minute ago about with your conversation with Dr. Martin. There probably is enough money in the system, not so much in terms of grants or in OHIP payments, but just in the value of the assets that we hold. As Phil says, some of our ideas about transitional housing reflects the fact that we tend to look at things within, say in the hospital sector, within the four corners of the hospital, rather than looking out the window and saying, that parking lot, that could be a senior's residence. And viewing our assets as being things that with some leverage we could convert to be part of the solution to our problems. And the same thing with other kinds of seniors housing. I mean, if we can keep people in their homes with chronic disease and with community supports longer than we do now, then all of the discussion that we heard with COVID about how comorbidities, or people with a number of chronic manifestations of their disease making it much worse, those things can be headed off and treated with a little bit more intervention earlier on, and that also will save us money. It turns out in this world, good medicine is also good finance if you handle it properly.
Well, the other part that you had mentioned, too, was more or less the roles that some of the foundations, the hospital foundations, would play in this, and how that they may have to turn the telescope around a little bit to get a broader view of what their impact and their resources could be put to.
Well, I think it's Phil may have an observation on this too. I mean, there are lots of claims on hospital foundation money, and most of those are within the hospital, particularly for equipment, because it's one of the areas that's less subsidized by government, and computer technology and things of that kind, which are increasingly important in the delivery of medicine. But I think it's also fair to say that there are ways in which we could make better use of the money that we have now, in terms of we create obligations. For example, some investments by hospital foundations have a bit of a bricks and mortar flavor about them, but the real cost is delivering the programs that are going to be conducted out of those facilities. So in simple terms, for example, if some of the rehabilitation therapies could be done at the YMCA or in the community rather than within the four walls of the hospital, that's probably a less expensive way to handle people with chronic heart conditions, or rehabilitation from orthopedic surgery and things of that kind. So there are ways in which we can just simply use the assets we have more effectively, I think.
Phil, have you got a final thought?
There's another source of funds that we haven't talked about, which is the pension funds that are always looking for good investments with steady returns. And that could be a partnership between hospital foundations, pension funds, government to some extent, and to build these structures. And there would be a return to a long-term return to the pension funds for their investment, for the equity required to build these type of structures as well.
Now, are we talking specifically about owning that space, or is this a rental model or a combined model, Phil?
Oh, I would say it could be a combined model.
Because I think that would be the attraction, right? That would be the attraction long term in terms of legacy income.
That's correct. Like long-term returns on the investment, because government sometimes doesn't have all the dollars to put in, but the private sector does have sources of funds to invest in this type of venture.
Well, it's an important discussion, and we have started it here. I hope that we can continue this further down the road, because it is going to be on the leading edge of the what's next as we move through the COVID pandemic. Phil and Michael, thanks for being part of the podcast. We appreciate it.
Thank you, Dave.
Thank you very much.
Thanks to Michael Fenn and Phil Rubinoff for being our guest today. You've been listening to Conversations About Construction, and we'd encourage you to subscribe to the show wherever you get your podcasts and share it with your network. Conversations About Construction is produced for the Residential and Civil Construction Alliance of Ontario by Eye Contact Productions. I'm Dave Trafford.